Between 3 and 8% of menstruating individuals experience functional impairment so severe it halts their lives on a monthly basis. For up to 2 weeks at a time, patients describe their baseline reality fracturing. They report sudden despair without apparent cause, rage at minor inconveniences, and an overwhelming sensation of becoming an entirely different person. Yet, when they present these symptoms to primary care or gynecology, they frequently encounter systemic dismissal. The condition is routinely written off as bad PMS. The DSM-5 formally recognizes this presentation as Premenstrual Dysphoric Disorder, or PMDD. PMDD operates as a distinct, complex mood disorder, separate from standard menstrual discomfort. The core psychiatric criteria include extreme mood lability, profound irritability or anger, deep depressed mood, and severe anxiety or tension. These are accompanied by intense physical symptoms like breast tenderness, joint pain, bloating, and crushing fatigue. This diagram illustrates a standard 28-day cycle. What separates PMDD from generalized anxiety or major depressive disorder are its strict temporal boundaries. To accurately diagnose it, clinicians have to abandon continuous psychiatric assessment models. The focus must shift to chronobiological mapping. Treating PMDD effectively means we stop viewing it as a routine gynecological complaint and approach it for what it is, a cycle. The critical window is the luteal phase, the final week preceding menses. In PMDD, severe psychological distress and physical pain cluster exclusively within this timeframe. Then, symptoms abruptly drop to zero and enter complete remission shortly after menses begins. Major depressive disorder and generalized anxiety disorder present as a steady, continuous baseline of distress. PMDD acts like a switch. The clinical picture is stark. A patient endures up to 2 weeks of profound functional impairment, followed by 2 weeks of total normalcy. During the symptomatic window, rapid cycling often forces patients to withdraw from relationships and employment. For clinicians observing severe mood lability, this precise cyclical pattern distinguishes PMDD from chronic psychiatric conditions. It also explains why standard psychiatric interviews, if they land mid-cycle during the symptom-free weeks, miss the diagnosis entirely. Patients often cannot accurately recall the severity or exact timeline of their symptoms once they are back to their baseline, making real-time data capture essential. PMDD is an error of biological timing. Its diagnosis must be rooted entirely in chronological data. A clinical rule dictates the next step. Retrospective self-reporting by the patient is medically insufficient to confirm PMDD. Recall bias obscures cyclical patterns. In the depths of luteal dysphoria, the patient feels the despair has lasted forever. In remission, they minimize how bad it actually was. The absolute clinical mandate is prospective daily symptom tracking. The standard validated tool for this is the Daily Record of Severity of Problems, or DRSP. This contrasts two approaches. Left, vague memory of a continuous bad month. Right, daily DRSP data revealing a clear luteal phase spike. The DSM-5 requires this pattern proven across at least 2 consecutive cycles. The data must prove the symptoms cause meaningful functional impairment, rather than just subjective discomfort. History must demonstrate this pattern occurring in most cycles over the past year. This rigorous tracking creates friction in primary care. It requires time, patient compliance, and persistent follow-up, which frequently leads to diagnostic drop-off. But once those 2 cycles of data are secured, the physician has an irrefutable mathematical map for treatment. Without prospective DRSP tracking, clinicians are essentially guessing. This daily data provides the evidence required to initiate targeted interventions. While lifestyle interventions like sleep regularity, stress management, and reduced alcohol are vital adjuncts, they are rarely sufficient alone to manage PMDD. This graphic shows the standard psychiatric approach, continuous SSRI dosing across the entire month. But PMDD presents an anomaly, luteal phase-only dosing. Intermittent dosing works here because the mood disturbance is tied directly to hormonal fluctuation, not a chronic neurotransmitter deficit. The secondary treatment pathway shifts toward hormonal interventions coordinated closely with gynecology. This involves using combined oral contraceptives containing drospirenone to suppress ovulation and stabilize hormone levels entirely. For severe cases, GnRH analogs provide a more aggressive intervention, medically inducing a temporary menopause to halt the cycle completely. These specific pharmacological and hormonal tools carry risks and require a highly precise diagnosis to be deployed safely. The final pillar of the clinical pathway is cognitive behavioral therapy. Generic talk therapy is insufficient. CBT must be explicitly adapted for cycle-locked mood disorders to help patients anticipate and manage luteal dysphoria before it escalates. Treating PMDD demands a highly specific algorithm, intermittent psychopharmacology, hormonal suppression, and cycle-aware psychotherapy working together. Despite clear diagnostic criteria in targeted treatments, PMDD remains dramatically underrecognized. The medical system suffers from a structural flaw. Psychiatrists generally do not track menstrual cycles, and OBGYNs are often hesitant to manage severe psychiatric medications. Patients fall into the resulting divide. Fixing this requires a deliberate, cross-disciplinary clinical network. Coping and Healing Counseling, or CHC, operates as an active model of this necessary integrated infrastructure. CHC provides a diverse, culturally competent team of over 15 licensed clinical social workers, professional counselors, and marriage and family therapists, all providing PMDD-informed therapy. This diagram shows how a dedicated therapy practice serves as the central hub. It coordinates the tracking of DRSP data and delivers specialized CBT, while communicating directly with medical providers to manage pharmacotherapy. Geographic and financial accessibility are paramount when treating a disorder that is already so frequently missed by standard care. CHC bridges the geographic gap by operating as a fully HIPAA-compliant telehealth practice covering all 159 counties in Georgia. They remove financial barriers through broad insurance integration. They are in network with major carriers, including Aetna, Cigna, BCBS, United Healthcare, and Humana, and offer a $0 copay for Medicaid patients. Clinicians and patients seeking specialized care coordination can access these resources directly at chctherapy.com or by calling 404-832-0102. PMDD is a measurable, treatable chronobiological disorder. It simply requires clinicians willing to track the data and the integrated network required to heal it.